Hi, my name is Lauren Haggerty, and I'm a second-year resident. My project is called Estimates of End-Stage Kidney Disease Risk and Timely Renal Replacement Therapy Education. Our question is, do kidney failure risk equations improve timing of dialysis preparation? A little bit of background here. The KDOQI guidelines recommend that patients with progressive chronic kidney disease be educated on renal replacement therapy to allow time for permanent dialysis access placement. That means we would hope that patients have extensive education on hemodialysis, peritoneal dialysis, and transplant. And should patients desire hemodialysis, we want to allow several times for fistula and graft placement and maturation. The timing of this education ought to account for each patient's risk of end-stage kidney disease as well as their comorbidities and preferences. We previously found that nephrologists tend to overestimate a patient's ESKD risk when compared to their actual risk and outcomes. The aims of the study are to determine if nephrologists' referrals to education are also overly aggressive when compared to a patient's actual ESKD risk. And we also aim to describe how the KFRE, or physician's estimation of end-stage kidney disease, are associated with these rates of education referral. The KFRE stands for the kidney failure risk equation, and this is an equation that predicts a patient's risk of developing end-stage kidney disease within 2 years. The factors that go into the KFRE are a patient's age, sex, GFR, their serum bicarbonate, albumin, calcium, and phosphorus, as well as their urine albumin to creatinine ratio. So 257 CKD clinic patients from both the VA and UCSD were involved in the study. The patients and their physicians were interviewed, their physicians being nephrologists here, and we asked nephrologists to estimate their patient's 2-year ESKD risk and calculated a patient's KFRE at that same time. We then used retrospective chart review to determine the timing of a patient's referral to education, the timing of end-stage kidney disease, and death if it happened. And then we examined referral patterns based on categories of KFRE estimated risk versus physician's estimated risk. Moving on to results. The average age of our patients were 65 years old, and the eGFR was 34 at time of enrollment. At 2-year follow-up, 9% of patients reached ESKD and 13% died. Interestingly, about 15% of these 257 patients were referred to renal replacement therapy education prior to their enrollment. Overall, as a patient's risk of ESKD increased, either as estimated by the KFRE or by a nephrologist, the rate of referral to renal replacement therapy education increased. Let's take a closer look at these images. So Table 1 shows renal replacement therapy education referrals in our low-risk patient groups. Low risk meaning less than 1% or less than 1 to 5% of developing end-stage kidney disease within 2 years. The top 2 tables here are patients separated out by a KFRE estimated risk, and the bottom 2 tables are patients separated out by a nephrologist estimated risk. Within each table, we separated patients into whether or not they developed ESKD within 2 years of study enrollment. And then the rows here show whether or not patients were referred to education either before they enrolled in the study or within 90 days of enrollment in the study. Overall, in these low-risk groups, the referral rates are quite low, and the patients that were referred to renal replacement therapy education actually did not develop end-stage kidney disease. Things get to be a little bit more interesting when we look at our moderate and high-risk groups. We determined patients to be medium risk if they had a 5 to 15% chance of ESKD, and our high-risk groups had greater than 15% risk of ESKD. We'll focus specifically on the high-risk groups here, and it's interesting to use the concepts of sensitivity and specificity to describe referral patterns in these groups. For example, when we use a KFRE estimate of risk, 21 of the 26 patients who developed ESKD were referred to education, which correlates with a sensitivity of 81%. Conversely, 12 of the 29 patients that did not develop end-stage kidney disease in this group were not referred to education, which correlates with a specificity of 41%. When we look at the physician estimated risk group, we have a sensitivity here of 68% and a specificity of 76%. So a couple of key takeaways here are that although we know physicians overestimate a patient's risk of ESKD, the referral patterns are not as aggressive as one might guess based on their concern for a patient's risk. And in the group where we use objective data, the KFRE group, to estimate risk, we find that referral patterns are quite sensitive and poorly specific. Thank you.